you. And I have to say thank you so much to Genome Atlantic and to Dr. Chris McMaster, who's been very hospitable in looking after me and in my brief visit here. And I'm very pleased at the fact that you have very nice lunch served, because the room I see is filled, maybe with people who only came for lunch, but that's okay too. They're here. So what I'm going to talk about is how do you use health economics to assess the value of sequencing for patients and families. But I'm not going to spend the whole time talking about that. I'm actually a health economist and health services researcher, so I'm not a medical geneticist. I guarantee that probably everybody in this room knows more than I do about genetics, so I apologize in advance if I say something incorrectly. But really what I want to do is think more broadly. We think about, what is the value of sequencing to patients? How do we measure that? So often people think about health economics and health economists, and they think dollar sign. It's about measuring costs. Or sometimes we get confused with accountants, which has happened to me in several jobs where people ask me to do things that I'm clearly not qualified to do. But with health economics, we're really looking at value. How do you measure the value? And in cost effectiveness analysis, value has two dimensions. One is effectiveness. You can measure it in lots of different ways. And the other is costs. And you don't do one without the other. You're looking at the value. It's a ratio. So if you get nothing else out of this seminar, that's important. And then the other thing is, how do we measure beyond what the cost is? And thus the title, which was meant to be provocative, and I'm glad it obviously intrigued a few of you, if nothing else. There may be a $1,000 genome, but is it worth $1,000? So you could say, wow, the price is coming down so much, it's cheap, relatively speaking, but is it worth $1,000? Is it worth $1? Maybe you would do more harm than good for patients if you actually give them all of the information that you get from sequencing. So we need to be thinking more broadly than cost, and think broadly about, what is the value of that sequencing to the patients and the families, and what are the positive things about sequencing, and what are the potential negative things or harm you could do. So this is what I'm going to talk about with respect to preferences and thinking more broadly. As I always say, I think Sue informed me that I should just keep going, but this is for you, so if there's something that isn't clear, please say so, and we'll try to clarify it. And I'll try to go through the slides quickly so that we can get to the interesting part, which is the discussion. So we'll get there. So I'll just talk a little bit about health economics, specifically around tools, one of them being how do you measure preferences to value health services, and give you a 3-second introduction to a method called conjoint analysis, which is a way to measure preferences. And then I'll talk a little bit about genomics and a couple of the projects that we're working on using these methods to try to better elucidate what that value is around sequencing. So Health Economics 101. What is it? Well, it's a specialized branch of economics. It's all about scarcity and allocating resources, essentially, and because it's in health, it's around health and health care. And I differentiate that health and health care. So there's services that are provided, but then there's the health of the individual, and obviously they're intimately linked in some ways, but there is a difference, obviously. So what's special about health? Well, we all need it. It's very complicated because it's not a normal market. It's much easier to do these things in a payer consumer market like the grocery store, where things are priced according to the market. And they find out very quickly if you're not willing to pay for something because it doesn't sell. That's not how health works. So we have a very complicated system for health, very complicated financing, and very complicated payment systems that make it very difficult, really, sometimes to understand what the value of things are. There's also this very asymmetric relationship between patients and also the providers who deliver care, although that's really changing, and it's really interesting in this day and age with the internet. because I would posit to you most of the time the patient's actually expert now because it's their disease, and they've actually often done more research than we would do in our lifetimes because it's so personal and so relevant to them, so that relationship's also changing. And the last thing that's particularly special around health is that what you understand or what you do or the actions you take in terms of your healthcare actually affect other people often. Not in all cases, but often. But certainly in the case of genetics, and we're talking about inherited kinds of diseases, you know, decisions or informations or how that patient who's in front of you could affect a whole lot of other people in terms of the management. So that makes it a whole lot more complicated to evaluate. Scarcity is a fundamental thing around in health economics. There's never enough money. There's never enough resources, whether that's people or equipment or infrastructure. So we can't give everyone everything, and the consequence of that is we have to make choices. Opportunity cost is fundamental, and that is thinking about, in any given situation, what is the cost of foregone outcomes that could have been achieved through an alternative selection of choices. So every time you choose to do something, you're sitting here, you're not doing something else. I don't know what that might have been, but the benefit here was you got lunch, and hopefully it'll still be a benefit because you maybe learned something interesting or thought of something as a result of the seminar. Could be a harm as well, but hopefully you'll come out net benefit because the sandwiches look very good. Thank you. But the implication of this, and I love this, this is old, it's from Anthony Collier, who's at the University of York health economist. And if you believe that, and if you believe that, then you should believe this. Because resources are scarce, it's actually ethical to be efficient. I know sometimes for clinicians that's a dilemma. You think, oh, I shouldn't be thinking about, you know, efficiency. I should be thinking and focusing on giving everything I can to the patient in front of me. But I could make an argument, and we won't get into this debate here, that it is ethical to be efficient and actually therefore also unethical to be inefficient because you're using those resources for something that maybe you could have used in a better way. Food for thought there. Your 3-second introduction to economic evaluation is basically looking at the costs and consequences and weighing them. We use the example of alternative A and B. Obviously, it's more complicated than that. But as a case in point, comparing two alternatives at least, and identifying, measuring, and analyzing the overall costs and the consequences of these alternatives. And the reason why I say that is, again, it's not, economics is not just about costs. You have to also be looking at the outcomes and the consequences in terms of health as well. So why do we need that? We have limited funds. We have to make policy decisions at some point because we can't do everything. What I like most about health economics, and when we're talking about decision modeling, is not that it necessarily gives you the answer, but it creates a framework for you to very systematically and logically go through the decision problem and document it explicitly. I think that to me is actually the greatest value of this, such that you can actually engage in an informed discussion based on evidence about what would be the right decision. So I think that's the thing I try to emphasize the most. And the idea is really to guide decisions so that we're funding the most cost-effective treatments. And it's an approach where we're assessing the value for the money. What are we actually getting out of what we're doing? So there you go. Now that you're all health economics experts, we'll talk about measuring preferences. So when I talk about preferences, it's really about understanding in a fundamental way, you know, what is important to somebody. And I guess there's lots of different ways to do that. One is what I've very generally termed here non-economic techniques, and that is where you don't have to make choices. So we can do satisfaction surveys, we can do opinion polls, or we can commonly do things, and that's why I actually got this, joking aside, state importance or rate things with surveys. So I will say this now because it's just sort of very convenient that you provided this survey now. This was not planned. But you can mark every single one of these as strongly agreed. In other words, this was a really good seminar. Excellent rating. Okay? Because there's no consequence of doing that to you, actually. You can rate every single thing here as excellent, right?
Hint, hint.
And it will be really good because they'll continue the seminars. There you go. You see, you didn't know you had such a good advocate. But the problem with that, we'll go on this on the next slide, is that people will say everything's important to them, right? If you're asking them about their health, for instance, yeah, I want to live long, I want to live the best quality of life, yes, I want to have low housing costs, yes, I want to have, we all want everything, right? It's human nature. So you want as much as you can get, but if you don't have to give up anything, well, you're going to take as much as you can get, and that's just normal, really. So this is the problem with these kinds of methods. Here are some examples, real examples as opposed to with your survey. Visual analog scale is a pretty common tool for measuring things. We have a study going on, it's about the next available surgeon. I'm sure all of you see in the newspapers about wait lists for arthroplasty, hip and knee surgery. So one of the things you might say is, how important is the distance to hospital where you have your surgery? Well, if I give you a visual analog scale, why wouldn't you put down extremely important? I would. It's very important to me. No consequence. Same with this one. You could use a Likert scale. So if I put these three things and said, well, how would you rate the importance of each of these? The length of the wait to see the surgeon, okay, so your consultation time, the length of the wait between seeing the surgeon and actually having your surgery, and then the travel time to the hospital. Well, if you filled that out, like I'd say they were all extremely important to me. Why wouldn't you? I mean, at some point. There's no consequence not doing that. But so in preferences, when I talk about preferences, and in its strict definition, we're actually talking about how do we learn what's important, but in the context of opportunity cost and choice. I'm going to make you work harder than those last two things. I'm going to say, well, wait a minute. You're going to have to give up something to get that if it's really important to you. So that's essentially what we're doing in preferences. And there's sort of a little history in economics. We've probably all heard of quality adjusted life years. The main direct methods for getting those or generating the utility measures from them are standard gamble or time trade-off. And then I'll just show you a couple examples of those. And then what I'm going to talk about here is a technique called conjoint analysis or discrete choice experiments, or a common version of them, which is a way of looking at trade-offs, but it allows us to go beyond health outcomes. It allows us to consider things like convenience, different modes of delivery, hospital care versus home care, processes to deliver the care. So you get a more complex or rich understanding of what people value beyond the actual outcome. So let me just show you a couple examples with time trade-off. This could be an example of alternatives that are offered. So you say, you do this face-to-face with people. You can be a paraplegic for 30 years and then you die. Or you can be healthy for 20 years and you die. So now all of a sudden, instead of saying it's really important that I live for however long or something, or it's really important that I'm not paraplegic and I have mobility, all of a sudden you're having to make choices. This is going to make you think much harder than those previous questions if I separated these out into different questions. So the way we get a utility then is vary these numbers, the time, which is why this is called time trade-off, until the person is indifferent between these two scenarios. The other method for qualities is a standard gamble, and there are others, but these are two main ones, where you're actually giving people a choice, and then they have a probability of different events. This is a more complex problem, if you think about this. And you vary the probability of the outcomes until they're indifferent between those choices. The point here is not to illustrate the methods of doing these things. The point is simply to say, this is making you have a choice, and your thought process, I guarantee, is different than when I was just asking you to say how important one single item is, one at a time. So that's why it's important to generate values. So conjoint analysis is the method I wanted to talk about, and I'm going to take those 3 examples that I showed you earlier, those individual questions that I was saying, rate them as how important they are to you. So if I presented this instead, it's still the wait time to the surgeon visit, it's the wait time to the surgery, and the travel time, but I gave you scenario A and scenario B, and said now you're going to have to choose. And you can see what's happening in there. There's some trade-offs where, yeah, if it's really important to me to have the hospital nearby in 30 minutes, then I'm going to have to wait 18 months for my surgery. So now, you go, well, I think I might be willing to travel for 6 hours to another hospital if I could be seen in 1 month. So all of a sudden you have to think about how you would trade those different things. There's a whole experimental design behind this, which I'm obviously not going into, but we can then statistically derive, using the experimental design underlying this survey, how important each of those attributes are, or factors, which are those things on the left, to the person, and we can actually quantitate that. So I could say it's twice as important that their travel time distance per hour is compared to having to wait for 1 extra month. So I can actually quantitate that for groups of people, and I can also do it for individuals as well using Bayesian techniques. So this all of a sudden becomes very powerful because we can use different metrics like willingness to pay, willingness to wait, and we can look at things beyond just the health outcomes. We can look at the processes and what people actually value in the whole delivery of the services. So the basis for conjoint analysis is really around choices, and what you do is have people answer those questions, and in answering those and making those choices, they're revealing what we call their preferences, and we can quantitate them. And the whole premise is really that something's only of value if you're actually willing to give up something for it. Health economics makes sense, right? You have to be willing to give something up. So that's the basic premise. So this is a very sort of illustrative history of preferences, and that is this is from Peter Newman's book. He used to be at Harvard, now he's at Tufts, but I really like this graph because it sort of gives you a sense of how much this is grown in the literature. So what this plots out is the use of cost effectiveness, either cost per life years or cost utility or cost benefit analysis over time in terms of the number of studies that are published in the literature. And you can see in the 1990s, all of a sudden, QALYs, which is the cost utility kind of analysis, just exploded. People really started to say we need to look at quality adjusted life years, we need to do cost effectiveness analysis. We were saying patient experience matters, and thus the QALYs. But then if I go one further, what's happened now is that preferences, or what we call conjoint analysis using choice experiments, is really also beginning to explode in the literature. This gives a similar kind of map. In the 2000s, we're starting to see this explosion in the healthcare literature because we're saying the patient point of view, or all of you have heard of the CIHR SPORE, I'm sure, the strategy for patient research outcomes, strategy for patient outcomes research, oriented research, I guess. This is really pushing some of this, driving some of this effort to say we need to understand what the patient actually wants, and the care needs to be patient focused, as opposed to just looking at mortality numbers, because it matters. And what's interesting here, so this stops at 2007, but if I plotted out the next 5 years, we haven't done that, then you would also see, very important from a policy perspective, the FDA and also the European equivalent, the EMEA, is using and considering how we should embed patient preferences measured using these techniques into their decisions about post-market surveillance on drugs. So they're now saying we want to be able to estimate the maximum acceptable risk that people are willing to take that's associated with drugs in order to keep them on the market. So they're starting to use these techniques in very policy-oriented settings. So conjoint analysis is a robust quantitative method. It's grounded in economic theory, utility theory, and what you're doing is measuring the value of alternative choices and looking at these risk-benefit trade-offs for specific attributes. And it allows you, as I said before, to look at different components. So you can deconstruct the aspects of a service beyond just the outcomes. You can look at costs, you can look at side effects, you can look at delivery mode for a particular service and figuring out how to do this. And that's really, I think, the beauty of conjoint analysis as opposed to quality adjusted life years. So this is my, my toy slide about preferences to make the point, because this usually gets it across very well. You have to make trade-offs, and you can think about a car. There are a lot of advertisements about cars on the television. I don't know if you've noticed. But color, sex appeal, price. You know, how do you trade those things? You can get the car on the left, or you can get the car on the right. Well, you know those are very different beasts without even having the numbers in front of you. So how do people make those choices? Well, some people get the car on the left. Some people, most people probably get the car on the right. So you have to think, and this is exactly what happens in market-based decisions about how you would do that. And your decision about that implicitly gives us how important each of those things are. Obviously, price being constrained by your income. And what we do in conjoint, and obviously this is meant to be a little joke, is say, well, how do you mix the two? You know, how do you decide what's the best choice for you in the end? Just to give you a little bit of context, because there's a whole history around conjoint analysis. The most common kind of conjoint analysis that's used these days, and particularly in health, is something called discrete choice experiments. They kind of mimic everyday life decisions in the sense that you decompose the attributes of a particular product or service, and then you give people a choice in a scenario and have them select one. So it's a fairly simple task for people to do. Typically, people have two alternatives, but often we use more than that. And sometimes we also, particularly in a screening context, use what we call a status quo or an opt-out option. And you have to have people choose an alternative. There is guidance on this. I've been involved with the International Society for Pharmacoeconomics and Outcomes Research, ISPOR as it's called, which has actually developed a checklist for conducting good conjoint analysis studies. It's basically a 10-point checklist which tries to give some good guidance about how to do conjoint analysis studies. And it basically follows, lays out the steps for you and gives you the best advice we have anyway at this juncture in terms of conducting a high quality study. And those references are available online. Here's an example in practice. This is around gene expression profiling in breast cancer and looking at the factors down on the left that you might consider in the different levels that you might provide in the survey. And here's an example of the choice task that you might give to someone. We've actually done this study, and basically what it's doing is asking people to choose between the first column, the second column, and the third column, considering the doctor's estimate of risk, the likelihood of temporary side effects, the likelihood of permanent side effects, your trust level in your doctor, which, as it turns out, through the qualitative work is very important in patient decisions, not surprising to physicians in the room. But that's actually a really important factor in the decisions patients make. And then also this JEP test. So there's a score, as you probably know, and there's also an estimate that you then give to people with respect to the likely benefit from chemotherapy. And that's basically what the clinicians involved in this study said or advised us to describe this as. So we have people choose, and then we ask them, would they really make that choice if they had alternatives available to them? So this is what the results look like. So this is the kind of information you can get out of preferences studies. we surveyed oncologists, patients, and the general population. So the most interesting thing, and I'm not going to go into the details here, is that there's a difference in the preferences of these different groups. Now that may not surprise you, but we can actually quantitate this now. So I can actually quantitate the difference in how people value each of those characteristics of JEP testing against one another. So these are all relative values, okay? And I can also look at the difference with respect to how medical oncologists, which is the blue line, compared to the breast cancer patients, which is the red, compared to the general population, actually value each of those aspects. So the most interesting is about your doctor's estimated risk of cancer returning, and the way this is shown, the way this is interpreted in conjoint analysis is that the medical oncologists actually value and would perceive their patients as valuing the doctor's estimate much more than the trust in the cancer doctor, the likelihood of temporary side effects, likelihood of permanent side effects, and it's about twice as much, and almost as much as the JEP test score. Having said that, the general population, the breast cancer population, does not value the physician's view as strongly. They actually also don't value the JEP test results as much as the physician, i.e. the oncologist, does. That's kind of interesting, but this is actually borne out by the qualitative work we did to develop this survey, in the sense that the patient in our work actually very much looked at what they had a preconceived idea about whether they should be getting chemotherapy or not, for a whole lot of other personal reasons. And what they did was they wanted the JEP test result, but that didn't actually really change their decision as to whether they were getting chemotherapy or not. So when you look at the context and look at the richness of the data around this, this actually makes a lot of sense. But if I had to go and think about, well, what is the utility of the JEP test at a rather expensive price tag of several thousands of dollars, I might reconsider whether it's actually worth doing that test. So food for thought. And then we can do scenario analysis and say, what would be the predicted uptake of chemotherapy in different scenarios based on those different attributes. Is conjoint analysis perfect? No. Is it really informative? Yeah, I think it is, actually. In the same way that I think decision modeling is informative, because it allows you to understand how people are making choices. It's a little bit problematic because you do have to limit the number of attributes you can consider, and there might be a lot more complex factors going on. You need reasonably large sample sizes. It obviously costs money to do these sorts of things, but it really gets you to understand more of the thought process around how people are making decisions. And there's a lot of discussion now in the literature about how do you incorporate this into guidelines and decision making. So I think we're okay for a couple more minutes. So what I'll do is just walk you through very quickly applications of this methodology to genomics. So we've got a couple studies going on right now. There's quite a lot of research in whole exome sequencing and whole genome sequencing around the value of a diagnosis. But the majority of this literature is the former type, i.e. attitudes or surveys or opinions, as opposed to preferences kinds of research, which I've just been illustrating to you, which would force people to make choices and trade things off. So in my parlance, I wouldn't actually call them value studies. We just call them attitude studies or surveys. So in general, based on this information, the literature sort of overall says there is great value to patients and families, even without definitive therapies being available. There's a lot of psychological benefits and emotional relief around having a diagnosis. And what our proposition in putting actually the Genome Canada grant together was that we really need to measure preferences in the way that I've defined it for you here today, to look at health and non-health outcomes that are not captured by these traditional kinds of attitude surveys. So discrete choice experiments have been used a little bit. There's not a whole lot of literature in this, but specifically in prenatal testing. And there are also some in the pipeline in terms of preferences surveys around whole genome sequencing that are coming out from Hopkins, actually. There's also literature around the return of results, and we know that people, the lifetime risk, the treatability, severity, carrier status, drug response, and total cost influence people's preferences. We know that it does depend on who's actually undergoing the testing. Again, this whole idea, which I was talking about earlier, that decisions made by the patient actually affect a much larger group of people around them, their families and other people. It does depend on the type of information that's returned. So there's this whole argument around whether the information that you give back on the results is actually actionable or not. How do you deal with the junk that comes back from these results? And could you, as I suggested early on at the very beginning here, could you actually do harm with some of that information as opposed to good with some of that information if somebody really doesn't want that information? So there's very little or no research, I always hesitate at no, but specifically around the value, in the way that I've defined it for you, of diagnostic testing information and willingness to pay, comparisons between diagnosed and undiagnosed patients, and really this weighing of the benefits and the risks and the trade-offs amongst different possible outcomes. And so this was really the premise in which we went into our grant, which I'll talk about in just a second. This is the slide that you've, I'm sure, seen a zillion times, but the reason why it's here is just to say that there's a difference between the costs, and yes, they're going down reverse exponentially, I guess, and what people are actually willing to pay, i.e. what is the value of that test. And so that's essentially what we're trying to get at in this research. So this is the grant that I was alluding to earlier, this Care for Rare with Kim Boycott and Alex McKenzie, which I think a number of you people know, in the Genome Canada grant that we were awarded. And this is really about the diagnostic odyssey. I'm sure you all know these numbers probably better than I do in terms of the long waits to get a diagnosis, the incorrect kind of diagnoses that are given or never receiving a diagnosis, and also the association of cost, which is pretty considerable around that whole diagnostic odyssey that patients with rare disorders go through. So our study, activity 2B, specifically around the economics and the value, has two components to it. One is around patient preferences, exactly as I've just been describing to you this method. And what we're going to be doing is valuing the diagnostic information around, or valuing diagnostic information using patient preferences methods, specifically conjoint analysis. And we're going to do it both in parents or parents of children with diagnosed rare disease and also undiagnosed rare disease. And that's actually a really important aspect of this, because we want to be able to make that comparison. And we'll be estimating the willingness to pay in the context of what is the value of a diagnosis to these patients. So the study looks like this in general. One of the things I haven't said a little bit here, but it's very important to do strong qualitative work to develop these surveys so that you're measuring the right things. So this is the plan. We're partway through the qualitative methods and expect to be fielding this study next year. And then the second component is actually measuring, this is just about the dollars, the costs of diagnosis now using administrative data from Ontario with the Institute of Clinical Evaluative Sciences. So we're going to have a cohort of controls and a cohort of cases and look at their healthcare utilization and costs. So trying to estimate with administrative data what the cost was associated with their diagnostic odyssey. And as I said, we're currently conducting the focus groups, Quebec, Ontario, and Alberta, and plan to field the survey itself next year. And then this is another whole genome sequencing study, actually. So we're doing a preferences conjoint analysis study looking at the value of information for whole genome sequencing and how people trade off risks and benefits in a healthy general population sample that's funded through NIH. And the idea here is, can it be used and what is the value of whole genome sequencing in a healthy population? And one of the things that's come up actually since we started this study is really around the ACMG recommendations on incidental findings. And who controls what results somebody is going to get? And again, it comes back to, is there harm that could be done if you give people back everything? Or are you withholding information by only providing, I think it's 30 results as a package of information to people? So we'll also be looking specifically around the willingness to pay for results, i.e. I want that result, and the willingness to pay to accept results, i.e. if you follow the ACMG guidelines, which says you will get these 30, maybe I don't want all of those 30. So maybe that's not good for all patients. So that's what we're going to be exploring. We're working with the group, the MedSeq group in Boston and Harvard. They have a randomized controlled trial for pre and post disclosure. So we're actually using that study to develop this survey, and we're going to be comparing our results for what people say they want to what they actually get after they reveal the results. Would they really have wanted that? So we're doing that component, and then we're doing a national sample. So what we're trying to do is really think about the decision context, the multiple results. If you package this as a whole report or give them single findings, each of them has potential downstream costs, and really try to get at the positive and the negative utility of the information that you're giving patients from your results. This is an example of our pre-test, which is actually going to field, I think, next week or the week after. So we took a long time to develop this, but it's basically a complex version of what I was showing you earlier, where people would choose whether or not they would want to see test result for gene variant A, whether or not they would want to see test result for gene B, etc. And they go through this decision on a one-by-one basis as to whether they want these results or not. And then there's a follow-up question about, well, who will decide what tests you want or not? So we'll be following up with questions saying, what if the expert said, you should have this test, but you didn't want it, should you be getting that or not? So that's how we're going to get at the willingness to pay and the willingness to accept test results to estimate the potential harm. So we're fielding that and should have the results by next year. And I said this already. So that's moving along as well. So that's sort of what I wanted to share with you, and I saved some time here for some discussion. So I know we went through some of those things a little bit quickly, but I think it's more important to have the discussion. So I welcome your thoughts on this.
And just a reminder, if you have a question, if you could just raise your hand and we can use the microphone. And we have about maybe 8 minutes before 1 o'clock, so if you have to leave, feel free to leave, but we may let the questions go a little bit, a few minutes longer past 1 o'clock.
This is Pat McGraw. We've been using a conjoint experiment, discrete choice experiments with Chuck Cunningham. I don't know if you know him.
I do.
But we're one of the things that we're finding very useful is to find out that there are different groups of people. So selecting different groups of people. Could you comment on that issue? Are you doing that? Is that the type of thing that you're interested in?
Yeah. So I didn't really talk about it very much, except to say very briefly, you can look at grouped preferences. So you can look at your cohort or your sample to see, what on average do people express in terms of their preferences. And then there's a few things that you can do. One, using hierarchical kinds of methods, you can actually estimate statistically individual preferences based on the result, because each person in the survey would receive multiple questions, right? It's not like you're showing them one, those are just one choice tasks. So you actually have a mini data set for each person who's answered the survey. So you can actually generate estimates at an individual level. But more importantly, and I think this is specific to your question, you can do what you call segmentation analysis, which is based on the results. And this is a little backwards than for those of you who are epidemiologists in the audience. But you would look at the results, and what you would do is identify groups of preferences within the sample. So in other words, I could then segregate the result and identify maybe 2 or 3 or 4, depending on the distributions of the taste preferences is what we call them, to say there's 3 or 4 different kinds of people. And then what I would do is figure out, well, what do those people look like? So instead of like when you're doing a cohort, so you may say, oh, I'm going to stratify by gender and age group and socioeconomic status or something like that. You actually work backwards, because what you do is find out what their preferences are and then identify what they look like. And this is actually what they call market segmentation, because remember, one of the things is that conjoint analysis is actually based in business and used a lot by companies in industry to identify our preferences. And they'll do focus groups to figure out why you'll pay more for Coke versus Pepsi. Well, they know how much more you'll pay for Coke versus Pepsi by doing these kinds of studies. So that's exactly how it's based.
Thank you. Deborah, thank you very much. Thanks for coming. It's a very nice presentation. You, at the beginning of your first section of your presentation, you made the bold statement that it's unethical to allocate resources inefficiently, and from a utilitarian point of view, yes, absolutely. I would agree with that statement. But now you've gone the direction you've taken this in your research, which is very interesting. But as we know, the value of a diagnostic test is how much it helps change a clinical decision, at least from a utilitarian point of view. Does this give a clinician or a clinician-patient dyad more information to change a decision that they wouldn't have made before, right? From a cost-effectiveness point of view. But now it seems like when you start bringing in patient preference into the decision, now you're taking this in a direction which you no longer may be as efficient if you start accommodating that in the decision-making process. For instance, you said that patients, it gives them, it relieves tension. I forget the specific words that you said. Right now, that's something that our healthcare system does not pay for, and from a utilitarian point of view. So I'd be interested in your thoughts about how this has evolved over time, because you've taken it one step further. It's very interesting. Thank you.
So we said we weren't going to talk about that slide, but nonetheless, it was meant to provoke. But actually, you do the perfect lead-in, because I think it depends on what it does depend on what framework you use to define what value is. And actually, I would argue this is a framework and a mechanism to actually incorporate patient views and patient values in a way that, no, we don't do so well right now, because payers, and we're just having that conversation an hour ago, actually tend to look at what they actually have to pay for. Personally, and I hope this is not going to get me kicked out of here very fast, but I think we actually have to change what our basic paradigm is in terms of what we value. And I do think that patient preferences should factor into that. I do not think that it is just about the quantity of life and the quality of life. There are a lot of other things that people value in terms of how services are delivered, and also in terms of, I guess, their mental health, if I could call that in a very broad way, in the sense of what works for them in terms of how you deliver those services and how it affects them and their family and others around them. So I do think our framework has to be larger than just that. But that will depend on how you define efficiency. You could still incorporate that within your paradigm of efficiency.
Yeah, that's a very interesting discussion. This is kind of a follow-up on what Adrian was getting, but I'm wondering, I was particularly struck with the data you had around breast cancer and oncologists' viewpoints and patients. So is there some way of, maybe it's impossible analysis, but is there some way to then follow up to see if when patient preferences are taken into consideration, are the outcomes any better or worse? And I guess better or worse is a difficult thing to define, but is that even possible, or can that be done, or has it been done?
Well, I think it can be done. I think you raise a very good question, again, with so much emphasis on patient-centered care now. I think we need to start doing those studies, but it will take time, obviously, because you have to be able to measure the outcome to see if it matters. So what I could envision is that you establish models of care where, you know, the patient has input. You could think of this in a randomized context, even where the patient actually guides based on their preferences, and you go through a whole shared decision-making process using these kinds of tools to make choices about how they get treated versus not. And I think you could be able to answer that question. So I don't think there's a whole lot of empirical, you know, randomized kind of trial study data around that, but I would argue there are less strong study design kind of data around it in terms of patients' satisfaction anyway, and probably similar outcomes based on going through a treatment process that they would have chosen. So I think those studies should be done.
Thanks for your talk. I have a two-part question regarding your the NIH study that you mentioned in the normal population.
Yeah.
And my questions, my two-part...
The general population?
The general population. So my question there first is, one, when you're getting information from the general population, it's obviously going to be at a specific sort of moment in time or moments in time, and that context may change. So even though someone is generally healthy and may even stay generally healthy, depending what's happening to their relatives, their friends, other things happening in their life, that may change the value of, well, this just happened, I just found out this about this friend of mine, I really want to know what's going on with me genetically because maybe this will happen to me. So that's my first question. The second one is looking at that in the US versus Canada in terms of the willingness of people to pay. Do you think those attitudes are different in the two countries based on the healthcare system?
So in terms of the first question, that's really about the stability of people's preferences over time.
Right.
And I would say absolutely, people's preferences do change based on context. So it does raise the question of, well, gee, if you actually wanted to incorporate patient preferences within, you know, some decision making, you probably can't just measure it at some point because it will change. So the question is, well, how would you do that? How frequently would you do it, or what time points would you do it? But I would agree with you, you know, they're not stable. People's preferences aren't stable. We probably change your mind 10 times a day, right? Depending on the moment. So yes. The second one, absolutely. We've done studies in the US and Canada and Europe, I mean, in comparisons, and people do value things differently. I mean, there clearly is a difference between the populations, and also I'm going to say their expectations in terms of health services. So we've previously done studies in colorectal cancer, for example, where we've used the exact same survey and compared in the US and Canada, and there are differences. There are some similarities in terms of the things, like in terms of the ordering of what they value, but the differences, but there are differences in the magnitude between the different attributes. So yes, we know that. There's also a particular sensitivity in Canada around including the cost attribute in your preferences surveys, because you will get some people who, what we call protest votes, which basically will say, well, I shouldn't have to pay anything because it's a publicly covered health service, and therefore, you know, it's not right that you're asking me. We very carefully pre-test these surveys and very carefully word the or the, you know, warm-up information, if I could call it that, to these surveys to explain why we're asking about cost. Not that we're trying to find out the cost or the price of what we're going to charge people for a service, but merely it's a vehicle to value things. So it allows us to have a metric that we can compare across the different attributes. So we word it very carefully to capture that.
I have a couple of questions. We have Andrew first, and then Lady Red, and then.
So, patients have preferences. The study design seems to assume that they can rationally implement those preferences based on probabilistic calculations. Yet the evidence is that people are terrible about making Bayesian type decisions, not merely in these sort of scenarios, but also, for example, in purely economic terms, in buying some stocks, etc. So do you think that the value of these sort of experiments is diminished by that?
Yeah, so you raise a good question, because numeracy in general isn't absolutely an issue. But what's really interesting, so again, we do pre-test these things really carefully and have certain specific ways that we present probabilistic information to people and do sort of tests and knowledge quizzes, I guess, in the survey as well. So yes, in general, I think that's a challenge. But what never fails to amaze me is that the results we get from these kinds of experiments are remarkably logical. So yes, I agree with you. It's based fundamentally on economic theory where there's some rationality to people's decisions, and people, as we well know, don't always behave rationally. They make choices that we don't think necessarily make sense sometimes. But if you look at these results on the whole, generally they behave, the data behave very well, actually, and actually normally are consistent with your a priori hypotheses about how people would prefer things. So yeah, you'll probably get results, some of them which aren't going to be perfectly in line, but on average, when you're looking at a large cohort, you have a pretty rich data set, they do behave reasonably well. We also, in designing these surveys, very carefully look at things like what we call dominance in terms of people making what we would call irrational decisions. So we study those things pretty carefully and then do sensitivity analysis with and without those survey results in it. And honestly, so far, and not even just on my experience, but based on the general literature, they give you pretty sensible results. So do I have concerns? Yes. Do I think if you're doing these things, you have to be very careful about that? Yes. Do I think they generally give you robust findings? Yes. Do you have to be careful about the fact that these are stated preferences as opposed to what we call revealed preferences, i.e. will people really behave the way they said they would on a survey? Probably not, but that would be the same as any survey. So if we make that argument, I would apply it to all other survey techniques as well.
Hi, I'm just wondering with your preference analysis of the whole genome sequencing or analysis, do you have any questions in there, or have you found in the past that people are concerned about the protection of what comes out of those surveys, specifically for insurance purposes, and if that would differ in Canada and the States as well?
The short answer to that is yes. But actually in the pre-work and the background work to this, we've actually debated this extensively. We are actually choosing not to include that as an attribute in this study because we actually feel that it's being well demonstrated already. So the answer to the question is yes. People are very concerned about how information would be used in an insurance context, and yes, that is a particularly U.S. phenomenon. So yeah, it's a factor that's important to people for sure.
Hi, thank you. I really enjoyed your talk as well. I also want to ask you about the breast cancer slide. There seemed to be a discrepancy, so people trust their doctors, and their doctors trust the genome sequence results. Is that what I interpreted correctly from? So the second one, there wasn't any difference. They trusted their doctor's opinion as an important factor, and the doctors thought that the genome test was important, but the patients didn't seem to think so. And I'm wondering, I guess, is that a reflection of they just don't know what the value of that is, so they just don't really, I don't prefer it, I don't not prefer it, I just don't really care about what you do with genome test because I don't know the value of it, sort of like if I went into my car dealer and I don't really care what they do back there, I just want a car dealer that's not gonna rip me off.
Okay, good analogy, but, so two things, and I probably went through it a bit quickly, sorry, because there's a lot of information in there, and I was just trying to pick out an example of something. But first of all, each of those results has to be interpreted relative to each of the attributes, right? Because what you do is you basically circumscribe a world in the context of doing these surveys that has these 5 things you're trading. So each one of those attributes is compared to the other. So all of your results are relative to one another. So it's not that they don't value something necessarily, it's relative to those others, they value it more or less, okay? So in the case of the medical oncologists, the value of the genome testing, the GEP test, is actually greater than for all the other groups, i.e. the breast cancer patients or the general population. And relative to the attribute of the doctor's opinion based on NCCN guidelines or current knowledge, what's your lymph node status and this kind of thing, the GEP test was valued more by the medical oncologists. The pattern is different for breast cancer patients, where they don't place as much emphasis on those things. It's not as important for them. So based on all the other information, you can see the pattern when you look at the demographic information and the experiential part of the survey, which basically explains it's all about context for them. One of the big things that drives the decision, so these are around decisions to get chemotherapy, going back to Adrian's point about what is the value of the test. Does it change your decision? And so what we found is that a lot of the times people have already determined whether they're going to get chemotherapy or not. So in fact, the test result isn't as valuable to them as one might think, because they don't place as much emphasis on it.
But I guess my question is, do they not place emphasis on it because they don't understand how important those results are to a to their oncologist decision making, or do they not place value on it? So if we're taking the patient's attitude into perspective, but the patient's attitude is to not look at information that their oncologist thinks is important, but listen to their oncologist. Listening to their oncologist then becomes less valuable if that information is actually valuable to begin with.
Yes. So good question. In all honesty, based on findings from that kind of study, you probably can't make that inference. You could suggest what direction those things might go, and I would argue this stimulates those kinds of questions, which is exactly part of the idea. And I would argue some of that is revealed again with the complementary information that we gather together. But I think the most important aspect of this is it forces you to ask those questions, right? Because my a priori on that would mean that GEP test would be much more important to the breast cancer patients, actually. So that's why it's so interesting to sort of explore more as to why that would be.
Done after one, clearly this could keep going on and on.
There we go. Now one knows how to fill out the survey.
And I found the second.
Number 5,
There's a
right?
reason why I ask people to fill it out, because if I wanted everybody to put 5 for everything, I would pick up 80 sheets and I would do it myself. So there is information that's valuable to us as well in terms of designing the next seminar series, but also going beyond the seminar series as well. So please do give the correct information. and
Did I make you nervous?
no, but it was a good point. And if anybody has more discussion questions, you can come forward, talk to Deborah. There's a bit of time before next meeting. Thanks.
Exactly.